I want to start by telling you a little story. So maybe it was a couple of years ago now, a patient came in to see me for a routine cervical smear test. And he was a little anxious, which is to be expected. It's pretty typical for the people I see. And I explained to him what we were going to do, and we did the procedure. Everything worked absolutely fine and no problems. And he said to me afterwards, "Thank you so much. I have been dreading getting this done. I knew I needed to do this, but I was so afraid to go and see my GP to have it done." And I kind of said to him, "Well, that's okay. You know, I'm happy to help, but you know, your GP, your doctor, the nurse there, you know, they do lots and lots of these. It's absolutely fine if you ever need to go back and have another one done." He said to me, "No, that's not what it's about. Okay, we know you. You know, my friends know you. That we see you in our community. It's so amazing having a trans woman giving care to trans people." And it kind of struck me at that point. Okay, this is part of what it means to be part of a community. This is I guess, a sense of responsibility that I have in delivering the service, that I can be that. I guess I can be that figure of trust that people have in me. There's a sense of responsibility that comes with that. So, as Sally said, my name is Nambiar. I'm a sexual health and reproductive health doctor. I also work as an endocrinologist in the Gender Identity Clinic in London. And I want to talk to you a little bit today about how we set up our clinic service called Clinic T. So, I live here, it's a city called Brighton, on the south coast of England. Some of you hopefully will know it and hopefully will visit it. It's a great place, an awesome place to live. And it's notable for many things, but one of them is that we have a significant trans population. A study that was done by the council showed that there were nearly 3,000 people who were trans and non-binary who were living within the city. That was done in 2015, which was almost certainly an underestimate at that time. And it's likely that since then we've had more and more people coming to the city. So it's not surprising that we have a really vibrant trans community. And this is a picture just from our annual Trans Pride. So setting up the clinic really allowed us to engage and to talk to a community. So I want to give you a little bit of history about how we did that. So cast your mind back to 2008. So we were involved with a study at that point. It was entitled "Count Me In Too." And it was really looking at provision of sexual reproductive health care. And one of the many sort of standout findings of that was that there were more trans people, a significant number of more trans people, 38%, who had never had any kind of STI screening at all, compared to 24% of cisgender people within the group. And one of the reasons, or many of the reasons that were identified for that, was that the trans population felt that the local sexual health information and services just simply weren't appropriate for our needs. So as a result of that, a program of community engagement began, and I have to credit a guy called Nick Douglas, who's a trans guy who was working with an organisation for LGBT-HIF at the time. And one of the things that came out of that was that people really wanted to have a sexual health service that was shaped by and run by trans people. So we undertook within the clinic a program of awareness training. We got people in to come and visit the clinic, to give feedback about what we needed to do, what we needed to change. And we launched Clinic T in 2012 in August. And it's from a slow beginning, we're seeing more and more people coming to the service. I'm really proud that it was a trans-led process from start to finish. Right through from the research, where people were involved, were trans people, through to the consultation, training, and then finally the clinic implementation. And I'm not trying to say that this is a novel thing or this is a new thing, because actually it happens elsewhere. our colleagues at Clinic Q in London did pretty much the same thing. They launched a little bit before us, around the same kind of time. I was this morning hearing an amazing presentation about the services that run at Calvin Ward Clinic and other services around the world that are leading the way in trans-led healthcare. And I think that it's really important that we bear that in mind, because the needs of the population are still there. This is some data from Public Health England, a reproductive healthcare survey looking at nearly 500 trans people here in the UK. And they found that within the last year, only 19% had had an STI screen, nearly 50% had never screened at all for any sexually transmitted infections, nearly 60% had never screened for HIV, and just under a third weren't aware of PrEP at all. So there's work yet to be done. So for us, we started as what was termed as a gateway service. And that was the way we had to do it for our commissioners. So within the National Health Service, our services are paid for and commissioned locally within sexual health. And the range of services that we can offer is sort of fixed by the commissioners. And what they said was that because people aren't coming to the service, if you can provide a way of engaging the community to come in and get screening and then come along to the regular services that are there, then that would be great. And we kind of said, well, that wasn't exactly what people were saying that they needed. But okay, to start, let's do that. So when we piloted it for the first year, what we found was that the evolution of services was more into providing specialist care, that specific services for the trans community. So that was, core services like STI screening, contraception, cervical cytology, vaccination, PrEP. All that stuff is covered and was commissioned. But people were asking us for additional things that perhaps were outside of the remit of what we were commissioned to do, and we were saying, okay, we can do this, but how do we fold this in? How do we expand the clinic to be able to accommodate this? So that included things like complex genital health care, management of symptoms of atrophy, chronic pelvic pain, psychosexual care, in particular, issues around sort of complex genital pain, issues around negotiating sex, difficulties reaching orgasm, all these sort of things, particularly in the context of gender-affirming surgeries, fertility and preconception care, and also management of gender-affirming hormones and gender identity care, which became something that more and more people were coming to us and asking about. And that's, for those of you who don't live in the UK, you may have heard that the waiting times and the demand for gender identity services here in the UK is, the demand way outstrips the supply that we can get. People are waiting a long time, and people are looking for care any way they can. And that's been really difficult for us. It's something that we've been able to do, but increasingly our commissioners are turning to us and saying that this is outside of the remit of what we are paying you to do. You can't do this. And so that's been particularly difficult. So one of the other things that we wanted to do was that in the process of setting up the clinic, we were starting to develop some guidelines. One of the things I thought was that, well, if we develop guidelines just for ourselves, then that's all very well. That works well for the people who are seeing us. But surely we can do this for other clinics within the UK. So we and a number of others all got together and said, how can we develop national guidelines? So we engaged the national governing bodies. This is the British Association of Sexual Health and HIV, and I chair the Gender and Sexual Minorities Special Interest Group on that organisation. And we have published a set of national guidelines for all sexual and reproductive health clinics. Very proud to say that's all come out. And we've also helped to feed into national guidelines here in the UK, this is quite a few years ago now, about contraceptive choices and sexual health, as well. This is from the Faculty of Sexual and Reproductive Health. The fact that these documents exist is great, but unfortunately we find that many healthcare providers either aren't aware of that, or haven't read them, or have been aware of it but haven't read it, which is particularly difficult. And a big part of my work is sexual health contraception. But for the last few minutes of this talk, I just wanted to turn the focus back onto pregnancy, because that's the main focus of this conference. And I want to talk to you about a case. So the issues that we had found were that liaison between different services, primary care, fertility, and gender identity clinic was difficult. I wasn't working in the GIC at that time. There were significant costs associated with fertility care. There's only certain things are funded within the NHS, within the public health system. And unfortunately, some aspects of fertility care aren't. So that raises a barrier for many people to be able to access that. In this case, he had to crowdfund that. And we were able to help in certain ways by limiting some of the costs, particularly some of the tests and the endocrinology care, but it still came to a significant amount of money that had to be raised. And also, much of the sort of social impacts that he and his family had to face, were touched on yesterday. Increased visibility, the media interest, all those other factors that we talked about. So that's just a little vignette of what we were able to do. So where do things lie in the future? And I think there is a challenge, particularly for us working within the National Health Service here in the UK, growing and developing services in a healthcare economy that's being ever more squeezed for resources. When I speak to commissioners, there's always this pressure to say, well, you're running a clinic that potentially could be folded into regular sexual health services. Could we do this elsewhere? Can people just come not to a specialist clinic, but to regular services? And I'm kind of trying to make the point that, well, the whole reason that we're here in the first place was that people asked us to set this up because they weren't going to those services. And we almost have a duty and a responsibility to make sure we live up to that, and we are delivering good quality healthcare. But there's a challenge of exploring new frontiers, particularly within trans-reproductive care. There's not as much research as we would like, and our patients are coming and talking to us about issues that start to set their mind thinking. I'm thinking particularly of a patient that came to see me not so long ago, a non-binary trans-feminine patient who was co-parenting with another trans-masculine person who was pregnant, and they asked me about the possibility of induced lactation and about co-breastfeeding. And there are case reports of that. There are anecdotal cases that I know personally, but there's very little research looking at the safety of that. And a lot of the conferences we've been talking about pregnancy in the context of trans-masculine people, but it's important to think about how trans-feminine people can be cared for within the reproductive context as well. But one of the things that about that particular issue that upset me a little bit was I'm talking to other healthcare professionals about looking for advice and expertise, where people would say to me, it's like, I'm not sure that we should be doing that. Not about could we do it, was it safe, which is a really important thing to be thinking about. What are the practicalities? How do we do this? But should we be doing this? And that really set me thinking. It really kind of almost upset me a little bit. It's like, let's not think about, we shouldn't be the ones making the judgments about whether people should or shouldn't be doing things. It's just a case of, I think, my personal opinion is that we should be thinking about how do we do reproductive healthcare in a way that is safe and appropriate for the patients we look after. And finally, the last thing, and probably the thing that I have the biggest passion for, is really for engaging and involving our community, really in shaping and delivering our healthcare. I think that, as trans people, we are at a point where we are able to move beyond just being the passive recipients of healthcare, but being the ones who are, being the architects of it and being the ones who go out there and deliver it. And I think that's why I entitled my talk "By Us, For Us," and that's the sort of the guiding principle in my work and what I want to achieve. So I'm going to leave it there by saying thank you to all, from my team, to all of you for inviting me to speak today. Thanks.